So let's get on to the first CPQA presentation of the day. Melissa Ross is going to present to us from the adult blood gas area. Melissa.
I didn't know I was going first. My name is Melissa. I'm from the Adult Blood Gas Lab. I'm a lab technician there, and I'm presenting data today on behalf of Heidi Friedenberg. She's the clinical technical lead in our department. And I'm going to talk to you about pre-analytical errors in the blood gas lab and how communication between departments can solve problems. First of all, what is a blood gas? A blood gas is a stat test. It can be done on arterial or venous blood. It's used to monitor patients in our critical care unit. It indicates whether the patient is in respiratory or metabolic acidosis or alkalosis, and it's ordered during codes and rapid responses to assess the patient's need for oxygen and medications. This is an example of a result from one of our analyzers. In addition to blood gas values, it also reports oximetry values, electrolyte values, and metabolic values. First of all, what state is the patient in that needs a blood gas? They're all critical patients. They can be in heart failure, kidney failure, they have lung problems, COPD, asthma, cystic fibrosis, uncontrolled diabetes, a severe infection. The blood gases are ordered in the critical care units on every new patient that comes in to obtain a baseline, and then routinely, usually at midnight and 6 in the morning, and that trends their progress. Then also any acute change in the patient requires a blood gas, such as an oxygen desaturation. Also, patients on ECMO need very close monitoring, and they can get blood gases drawn every 2 hours. If there's a rapid response or a code, they draw blood gases throughout the code, and they can be drawn every 10 minutes. The results tell us whether the patient's condition is improving or declining, and they also inform us on how to treat the patient, whether they need more oxygen or meds. Pre-analytical errors that can happen in the blood gas lab include mislabeled samples, samples without a label. There could be air in the sample, hemolysis, a delay in testing, insufficient mixing of the sample can cause problems, dilution of the sample due to IV fluids, and clotting. Up to 60% of the errors in the blood gas lab occur in the pre-analytical phase. Every month, data from each unit is reviewed, including episodes of downtime and amount of sample rejection and test cancellation due to pre-analytical errors. And today I'm going to talk to you about clotting. This graph represents the frequency of downtime on our analyzers due to clots in 2012. 5D and 6D are our busiest units. We have 2 analyzers on each of those floors. And as you can see, 5D has an alarmingly higher rate of downtime due to clots as opposed to 6D. Clots happen when the heparin that's in the syringes doesn't get moved through the blood properly. The syringes contain a block of freeze-dried lithium heparin, and that prevents electrolyte bias in the results, and it also prevents dilution that's associated with liquid heparin. If the sample is not adequately mixed right after it's collected and before it's analyzed, it will clot. And this picture is of the inside of our analyzers. There's very small tubing that goes through these membranes, and so the clot can easily get trapped in there and prevent the result from being obtained, and it can also shut the machine down. Sometimes we're able to fix it ourselves, and sometimes we have to call a technician to come out. This can put the machine down from anywhere between 5 minutes to 24 hours, and it's a big problem because when those routine blood gases are getting drawn at midnight and 6 a.m., you can get a sample from every patient in the critical care unit all at once, and if you only have one analyzer, you're going to have a problem. What Heidi did to check it out was take it to the floor, which I've heard is Gemba, which is part of lean. She observed an 8-hour shift to see what the nurses and the respiratory therapists have to go through to get a sample. First, they activate the order, and then the sample's retrieved. The sample's collected and then dropped at the lab window. And unfortunately, this can take anywhere from 5 to 20 minutes because the patient may be a contact patient, in which case the nurse would have to gown up before collecting the sample. There are also only 2 label printers, I'm told, per unit, so they're having to leave the room, ungarb, get the label, go back in the room, guard back up, and collect the sample. It can take a lot of time. We only have 30 minutes to analyze the sample from the time that it's collected, or else it's unacceptable because of the metabolic changes that occur after it's been drawn. Next, the sample is received into the system, mixed, analyzed, and the results are distributed. The outcome of this observation was that the sample was not being inverted at the bedside, there was inadequate mixing before analysis, there was a failure to check for clots before analyzing, and most importantly, the use of the 1 cc syringe on the unit as opposed to the 2 cc syringe, which we use on every other unit. The 1 cc syringe is pictured here. It has a small barrel, which makes it difficult to mix the blood through the heparin properly. It also has a loose plunger, which can lead to the loss of sample during the mixing process. It's difficult to remove small air bubbles from it, and it also has a low sample volume. The minimum required for a blood gas is 0.5 cc's, and if it's a critical result, which it often is, it needs to be rerun for confirmation. So if you only have 1 cc altogether, it's a little tough to do that. The solution to the problem was to meet with the clinical nurse specialist and discuss the outcome of the observation, and the procedures were reviewed with the floor nurses. Next, they talked about the 1 cc syringe, and the unit had been using it because it was a lower cost. So the benefits of switching back to the 2 cc syringe, which is pictured here, would be that the supply cost would actually be lower because of the less samples being recollected and reanalyzed. There would also, most importantly, be improved patient care due to increased turnaround time and fewer redraws. Next, she met with the respiratory supervisor, and they decided to revise their procedures to include that the sample should be mixed for at least 1 minute and that they should be checked for clots prior to analysis. This is a graph showing the average number of samples that were, the number of samples that sent the machine down due to clots in 2013 in red here. So that's after the introduction of the 2 cc syringe. So you can see there's a drastic decrease in the amount of clots after switching to the 2 cc syringe. So we did a good thing. In summary, by opening the lines of communication between the floor and the lab, we can work better together in the future to set each other up for success. Our goal is to obtain the most consistent and accurate results for our doctors, nurses, respiratory therapists, and most importantly, our patients. Thank you.
Well, that was a fantastic presentation. It's nice to see us solve something, and actually we saved lots of samples. We saved the loss of the instrument for a period of time. Are there any questions about this?
What kind of patients are in 5D and 6?
5D is SICU. 5D is SICU, so it's the surgical ICU. They also carry the overflow from 60, which is CCMU. That's the main critical care unit. And so anytime any of the ICUs are full on 4, 5, 6, 7, 8, they get sent to 5. It's like an overflow, and 5D also does transplants. So basically anytime somebody fails to wean from mechanical ventilation after surgery, they're sent to 5D because the operating areas don't have enough beds to keep all the patients there. So if they don't get up and wake up and take time to really SICU.
Any other questions?
Thank you.
Thank you very much.